Talking about floaters as a symptom, and I guess I live in a world of floaters, and from about mid 2018 we got this ability to do YAG vitreolysis. So suddenly there was YAG vitreolysis and vitrectomy as a way to deal with symptomatic uncomplicated floaters, and so I really wanted to sort of go back and just get a feel for the people who are presenting and whether they got a vitrectomy or whether they got a YAG vitreolysis and which group goes where. So I presented this at the Bransco branch meeting last year, but I thought I'd just start off the presentation by just sharing it with you. So laser floater treatment or vitrectomy. So this is my retrospective case series. So the most important thing is that floaters have a broad differential. So the primary thing is not even how we're going to treat this, but what is the cause? What's the we need the if we're going to treat them appropriately, we need to know exactly what's caused the floaters. So there are two sorts of floaters. There's primary and secondary floaters if you're going to start classifying them. And the primary ones are just the opacities that arise, from the vitreous cavity itself, and that's really just due to degeneration of the vitreous gel. So that's the syneresis where the collagen starts to degenerate into debris that we can start seeing, and the PVD process. And then the secondary floaters are the things that arise from outside the vitreous cavity. So you have a PVD plus, there's some bleeding from a retinal vessel into the vitreous, or there's created a tear, or it's detached. And of course there are many causes actually of vitreous hemorrhage, not just PVD related. That's just one cause. Yagging a posterior capsule. I'm sure you guys have sort of seen some debris floating around in the anterior vitreous, which can be quite symptomatic for some people. And then this is, I thought it was my laser pointer. No, and this is a big one here, this inflammatory eye disease. And you've got to really make sure, well, actually these floaters are, if they're inflammatory eye disease, then it's got, it requires a whole different workup. Asteroid hyalosis. I always find it beautiful to look at when you see it, just swirling around in there. And then occasionally, floaters can be a sign of tumours inside the eye. I mean, it's incredibly rare. I mean, probably in Christchurch, I was talking with Jim Borthwick, and probably in Christchurch over the last 20, 25 years, there's been half a dozen cases. So it's vanishingly rare, but yes, floaters can be a sign of lymphoma. So why would you treat vitreous floaters due to the PVD process? Well, for the majority of people, floaters are of absolutely no consequence whatsoever, and a lot of people just neuroadapt to them. So I sort of say to people when I first see them, well, there's a 95% chance that in 3 months' time your brain's kind of tuned this out. And of course, some people say, well, has the floater actually gone away? And then you get into this conversation, well, actually, no, it probably hasn't, but your brain's kind of just accepted it as part of the furniture, and it's still there if you look for it, but kind of don't go around looking for it. But for a minority of people, floaters are absolutely debilitating. It just drives them insane, and it really affects their quality of life. So how do we assess the severity of floaters in the clinic? Well, first of all, it's all on the history, really, isn't it? Looking at the computer, if they've just got that uniform white background, all good. And they've got debris swirling around in the front, or occupational demands, particularly those discriminating personality types like engineers and pilots, and then there's just the personality factor. Sometimes when I see someone with floaters and we're talking about, will you come back and see me in 3 months' time if they're still bothering you, and I go to myself, note to self, they're going to be back in 3 months' time, because you can just tell from their personality type, how particular they are, how discriminating they are, how bothered they are about it. And then that kind of distress that goes with it as well. And then obviously you examine the vitreous cavity, see what's going on. Studies have objectified, with all these quality of life questionnaires based on floaters. I must say, you can get there's no end to how academic you can get about it, but in a real world clinic, I haven't gone there. And then there are objective tests as well, like tests of contrast sensitivity, because floaters significant floaters really interfere with contrast sensitivity. It's not so much, black on white like the typical Snellen chart, but if you think about, grey on grey. So this is just with the iodine and the near infrared with the spectralis, and you can see, there's a floater here, and in this it's the same person, same floater, but it's in a different place. But these photographs don't really do it justice because the eye is so dynamic. So if you suddenly do an OCT through that floater there, then bang, that's the shadow. It's pretty dramatic, isn't it? I mean, that's quite a opacity, and that's not far in front of the retina. So that if you've got this thing washing around in front of your macular region, that's friggin' annoying. And as I say, it's a dynamic thing. So this is just prior to removing those flow. Look at that. I mean, look at that big soup rolling around in there. And that's what I've, shown you. I don't usually start my operations by wiggling the eye around, but sometimes I do actually, because it's nice to show the team around you. Well, look at this. How friggin' annoying would that be? And everyone nods their head and go, yes, that would be friggin' annoying. So, but that, just realize, it's just a dynamic space, the vitreous cavity. It's constantly swirling around. So, treatment options, well, traditionally it's been conservative, this whole concept of neuroadaptation, give it 3 months and hopefully it doesn't bother you anymore. Vitrectomies, a totally definitive intraocular procedure, and I tell people that, I can get rid of 99% of their floaters with vitrectomy. But yes, if they sit there and, look at a white wall and flick their eye around, they might sort of see a shadow or two. And you always got to have that clause for some people. And then more recently, there's been YAG vitreolysis or laser floater treatments. It's actually been around for a while, with the first case series reported in 1993. But they're all small case series with varying treatment protocols. It's being approved as a surgical device in Australia and in Europe, but not by the FDA, so it's very much a off-label treatment in the United States. And we've had this Alex reflex machine in Southern Eye Specialists from mid-2018. So what I did was just this retrospective case series, and I was just trying to get a feel for, for the people I embark on this conversation of doing something about your floaters. I wanted to know where did it all go, basically. So I just sort of searched back through our electronic medical record, free text search for any time, I'd entered the word vitreolysis or it had been in any of the letters. And then also search the surgical databases where I'd, done a vitrectomy for floaters or done a YAG vitreolysis. So over that, just over a 3-year period, it added up to 125 people, mean age 62, pretty even male-female split. And so this is the key to success or failure, this one basically. So I've got my group of 125. And so it's all about triage, basically. It's, what's going on here, what's the most appropriate treatment. If we're going to do something about, and I'm talking about sort of standard PVD or synuretic related floaters, okay? This is just nothing else. It's not inflammatory eye disease, it's not asteroid, it's not all the other stuff, it's just PVD related events or synuresis. And so I sat down and thought, well, okay, I reckon, 48 or 38% of this overall group are suitable to have YAG vitreolysis, and the rest, the majority of the group, 62%, not actually. And we'll drill down on all of that. I keep forgetting to use this. So who's suitable for laser photo treatment? Well, I mean, as I say, I feel they have to have been symptomatic for over 3 months. It's the right thing to do to give them that period of time to neuroadapt at all. There's no point doing procedures for symptoms that are just going to settle down. And the other reason for waiting 3 months as well is that, in the vast majority of people when that PVD process happens, it's just a one-off event, and 100% of the PVD kind of happens straight away. But for a bunch of people, and it's absolutely the minority, it's probably, certainly less than 10% anyway. It's a bit of a staged process where 80% of your PVD might happen, and in fact, there's still more to go, but you don't know when it's going to go. And the reason I know that this happens is that some people come in with a PVD-related retinal tear, and then you sort that out, and then a week later they've come back with new floaters and they've got another tear, and you know damn well that tear wasn't there last week, so that PVD has just continued to progress on. So that's a really good reason for waiting before I intervene, because I don't want them to think that my treatment caused them to get a retinal tear. Okay, so I really want that whole PVD process to have finished. And this is a really, this is the key one really, a PVD and an isolated vice ring. Okay, even if you take nothing else from this talk, that is the bottom line in many ways. And so but conversely, I want this person to say that there's a dominant floater there, and I look in and I can see a vice ring, and it's in the mid-vitreous cavity. It's not just in front of the optic nerve or in front of the macula, because there's going to be sort of energy dispersion from the lasering it at that site. And the other thing is it's got when you start lasering these people, you can only really get to the floaters that are in the line of sight, okay? And sometimes they just sort of kind of sink down and they just get beyond your ability to laser off axis. So it's got to be something that I can see, something that I feel that they're seeing, and I can safely laser it. And so the other thing, if you have a look at this as well, this is, you see, bang, see all that murk just behind the lens there when they look up and down, okay? And so there's not much point. So I've really gotten to this habit now of actually really searching the vitreous cavity as well, because just because, I see a vice doesn't actually mean that that is the floater that they're complaining of. And this is what I've learned as I've done this. And I have, this 125, it's a bit warts and all, this case series, because it absolutely includes my learning curve, where I sort of worked all this stuff out. So I'm constantly, get them to look up, down, left, right, and I'm looking for, kind of bumblebees like that are just bumbling around behind the lens that there's no way you can laser them. So, if there's anything like that present, I go, no, I can't actually help you. So who are the ones that are unsuitable for laser floater treatment? Well, they've got a PVD plus, lots of vitreous debris, lots going on, more than just, an isolated vice ring, okay? Retinal tears, I've lasered a few people with retinal tears, and there's just too much, cellular activity from release of RPE, and I just don't think it's sorting out their vice ring, they're not that satisfied. As I talked about, if the vice ring's too close to the posterior pole, it's not safe, or if it's sinking into the vitreous, I can't get it either. The other ones that are unsuitable for LFT are the people who, and they're saying, I've got floaters, but they haven't actually had a PVD. So they haven't had a PVD, they don't have a vice, but they've got either, synuresis with the degeneration of collagen, and you can see it, they can see it. And, I sort of describe it as nebulous clouds, basically. And you can't laser nebulous clouds because, the beautiful thing about a vice ring is, you know where it starts and you know where it stops, and it doesn't sort of, have tentacles that go out into the periphery. With a nebulous cloud, where does it start? Where does it stop? You start sort of following it out, and then you start getting into the danger zone because you're suddenly not in the mid-vitreous anymore. This is something I've worked out as well, is that if they've got other things going on that reduce contrast sensitivity in their kind of visual apparatus, then getting rid of a vice ring ain't going to help, because they're still going to be bothered by all the other floater debris. And that's people with monovision in particular, and also these group of people with premium lenses in them. Okay, these premium lenses, we only put them in people who have got otherwise a really healthy set of eyes, and it's not uncommon for someone to have cataract surgery, premium lens put in, they're all happy as Larry, and then 3 months later they walk in with a PVD, which has probably always going to happen, but a little bit of low-grade inflammation inside the eye after a cataract operation has brought that event on, and they've got all this muck swirling around in their eye, and suddenly they're not happy. Because the reality of it is those premium lenses, as they decreased, they decreased contrast sensitivity, don't they? You don't get 3 focal planes. There's no free lunch in optics, is there, with 3 focal planes? And then the other group is people that I can't make happy with YAG vitreolysis is if they've had a vitrectomy in their fellow eye. Because if they've had a vitrectomy in their fellow eye, they've got true optical clarity, okay? And you can't compete with that by lasering a floater. And then, of course, you're just sort of trying to, manage the expectations as well. So yeah, the other one is just putting in a port again and just looking at, so this is just debris from yagging a posterior capsule. It's all just sitting there. And the thing about this, you go, why can't you laser that? But the thing is, this person's lying flat on their back in an operating theatre. Okay, if you put them in the machine there, where they're sort of slit lamp based, then it doesn't stay there. It all sinks down into the inferior vitreous. So you can't actually get it. So it's a little annoying, but also there's just so much of it there. You can't, you can't make it all. You can't vaporize it all. So what about, okay, so I, out of the original group of 125, identified 48 people who I said to them, I think, you'd be a good candidate for YAG vitreolysis. Obviously no one has to have this procedure, and it's not funded by insurance companies at all. So a self-selected group of 24, so half of the group decide, yeah, I want to have this done. That's 24 people, but 2 have them bilaterally, so it's 26 procedures. Okay, but unbeknown to me, this is my learning curve. Okay, so that group of 26 actually, in my first 24 people, included 6 people who I now wouldn't do. Okay, so I learned a lot from this group of people, and I reimbursed some laser fees as well, just to satisfy my conscience. So, the people who had a PVD and a vice ring, that was 20 out of this group of 26, and they were happy with this procedure. I think I, made things better. You can't make the floater absolutely go away, but you just try and drop it down. The terminology I use is kind of drop it down below their visual radar. It's still there. It's still there if they look for it, but hopefully it's just, become faint enough so that they can just carry on with their normal, whatever it is, their activities, and not be bothered by it. So these are the people who I feel like, I did the vitreolysis on them and it wasn't the right procedure for them. And this is, the PVD plus the vice, sure, but also they've got this big nebulous cloud that's bumbling around as well that you've really got to look for, which is something I'm a meticulous now. Or they've got a retinal tear, or they haven't actually had a PVD. And they've just got this nebulous clouds, and you can't make that go away. And then anyone who's in inflammatory eye disease as well. I mean, this person had toxoplasmosis, and they just had this friggin' huge vice, and I thought it was worth a go. But there's so much inflammatory load going on in there that I just don't think it's the right procedure. But 20 out of 26 were happy, and as I say, this is my learning curve, I guess. So I've I'd say. Things have improved since then. In terms of the treatment protocol, well, I really like to, I don't like other distractions while I'm doing this. The thing that's different about this sort of laser is you're lasering a moving target. Okay, it's yes, you've got a contact lens on this on the eye, but it's still moving around a little bit. Everything else I laser is in the same place. The posterior capsule doesn't move around at all. When you laser the retina, it doesn't move around. This thing is absolutely mobile. And so I'm being really clear, because when you're lasering, sitting there at the laser, you can't see the posterior surface of the lens. If they're phakic, you can't see it. So you just have to be absolutely clear about, where it is. So, I just clarify what I'm going to get them in the chair again, have a look again, time, just talking about this procedure, bit of iodine, get them all nice and comfortable in the laser room. You've got a series of lenses that I bought at the start quite optimistically, and there's only one lens I use actually. There's another one for a very long eye to sort of get me a bit more reach into the vitreous cavity, but I've got all these prismatic ones that supposedly help me laser stuff that's off the visual axis, but I can't get them to work at all. And I'm sort of the other important thing is that when we do a YAG posterior capsulotomy, so lasering, so you can just imagine the, front of the eye, back of the eye, the lens is there, and you've got the posterior capsule behind it. We always sort of offset, you've got a fixation light, and then you've got where the energy happens, and so we always do it so that the energy is offset posterior to the fixation light, so that if you haven't quite got it right, then you're not pitting the lens or anything like that. You know, the photo's disruptive event is happening more posterior, but I don't want that at all. So, you know, it's always set on that 200 microns posterior offset. So I just remove the offset. As I've talked about, it's a mobile target. I give them, when I started, I used to check the pressure 30 minutes after the procedure, but I'm pretty conservative about how much energy I pump into the eye, so I've stopped doing that. And I give them Maxidex 4 times a day for 4 days, and then next visit they come back, and we'll talk about the number of next visits. So, yeah, we talked about the laser. Yeah, the end point is this kind of, you see like champagne bubbles, and you just, you sort of vaporizing just sort of these little bubbles, but the patient sees them, retina averts everything, so they sort of see them dropping down to the floor. So what's the treatment endpoint? Well, it's like a lot of things in VR. The treatment endpoints are not precise, and they're rather subjective. But just comments like, yes, 80%. These are real patient comments. 80% gone. I can live with it now. Can't see it. Not bothered. And then from my point of view, either it's too faint, and I can't see anything more to usefully laser, or it's too mobile, or it's suddenly not in a safe place. And this is another phenomenon I've realised as well, is that if you get rid of their dominant floater, some personality types start tuning into the next order of magnitude of floaters, which is, that's what the brain does. That's what discriminating, brains who are hunting perfection with floater removal start doing. So of course, YAG vitreolysis is not the procedure for them. They need a vitrectomy. But that's just a really interesting phenomenon that I've sort of tuned into. So this was, the treatment summary of these people. So this is the number of treatment sessions they had, anywhere between 1 and 5, with the average, being just over two treatment sessions. Okay, and so this is the number of people who had. There's sort of 20 out of the group had 27 had just 1 or 2 procedures. One person, so this was my learning curve. This person, young person, no PVD, extensive nebulous floaters. Optimistically, I gave her a refund because she was 5 sessions later she wasn't any better off. And this is sort of the energy. This is the total energy that I'm putting into the eye. For the one procedure I'm pumping in about 260 millijoules. 2 procedures at 650, and it just sort of carries on up. Basically, this person got a lot of energy put into the eye. But at each treatment session, I'm not happy to. I'm happy to go up to about 5 joules. 50 millijoules, so that's 500 millijoules, so 0.5 of a joule. And then I say, well, I've done as much as I'm prepared to do. So, this is really just a summary of what I did. If it's a PVD and isolated vice ring, they're happy, it's worthwhile. Add in, these are the red is, not happy basically. So the nebulous clouds, the retinal tear, no PVD in nebulous clouds, so that's all synuresis, and then toxoplasmosis. As I say, with the nebulous clouds, you just can't treat them. Where does the floater start? Where does it stop? And then you start wandering around and following things. So in terms of complications, well, I've only had one. It was a major one. So pressure's been fine. I'm really, I'm really meticulous about, if it's right in front of the macula or the disc, and how you can tell that is if you've got the floater in focus, if you can sort of, the posterior pole should be really blurred. It's got not clear, but if it's clear and you can go, I can see a retinal blood vessel there, I go, this is just a little bit too close. Unfortunately, I did manage to do this. There it is there, bang. It was a really, really sickening moment when I blew a hole in the posterior capsule of someone's lens. And so this was the scenario. Again, no PVD, extensive nebulous floaters, and you just start following the tentacles of this floater out into the periphery, and you, more dangerously, you start following it forward back towards you, coming back towards the posterior surface of the lens. So, obviously, that's what it looked like initially, and it's just it was really slow cataract development, over a couple of months basically, but if you're bothered by floaters, you're going to be bothered by, feathering of a cataract developing. So, he ended up having, it's a cataract, it's a complicated cataract operation, isn't it? Because it's already a hole in the posterior capsule before you even start the operation. Sorry, humour is the way I deal with stressful situations. So, that's the reason for my laughter. So, they needed a combined phaco-vitrectomy, but, nice anterior capsulotomy and reverse optic capture, pushing the optic through the anterior capsulotomy of a sulcus lens. And then, because as soon as you start doing that, you're not putting the lens in the bag, you get an increased rate of refractive errors, and they're not happy about that. So, bit of LASIK, and now, floater-free and 6:3 vision. Really happy. But it was quite a process. Okay, what about the people who are unsuitable for, and that was the majority of the group who are unsuitable for YAG vitreolysis or latest photo treatment. So again, this is not a procedure you have to have. So there were 77 in that group, and 20 people decided to go on to have vitrectomy. Having 24 procedures, so that means 4 of them were bilateral, and the vast majority of them again were PVD related events. A couple in here are people who've not actually had a PVD, and then there were a couple of people who just had these large fragments after YAG capsulotomy. This is an interesting group of people, the people who haven't had a PVD yet, because and I'll show you some surgical videos just to crystallize the concept in your mind, but there'd be when I do that procedure, then I've got to surgically separate the posterior hyaloid away, and that's the one time that I can't control the forces that are going into the retina, because the hyaloid's stuck onto it, and you've got to surgically strip it away, and so you can get retinal tears, which obviously need endolaser, gas, and then cataract, and da-da-da-da-da. Excuse me, but it just shows you, the one that really sticks in my brain here is a builder. He's builder, and he's amblyopic in one eye, so he's only got one eye. He's a one-eyed builder, and he's got all the syneretic floaters, and it's just completely messing up his career, basically. He can't even sight things anymore, and so suddenly you've got someone here saying, I want you to operate on my only eye, and they haven't had a PVD, and you're going to have to surgically strip it away. But at the end of the day, it's, you discuss risk benefits with people, and he goes, in sort of thing. And so, we did the procedure, and sure enough, get retinal tears, and so there's gas and laser, and there's a cataract, and then there's COVID. So everything gets a bit delayed, but you get there in the end. So what I'm saying is that I think the vitrectomy's got to the stage where it is a definitive procedure. It's a good operation. There's a low risk profile. It's not zero risk, but it's very low risk. But in these scenarios, these people are so bothered that I feel it's the right thing to do. If you inform them about it, that it's a reasonable thing to do in these sort of exceptional situations. I'm sure 20 years ago that would have been seen as the devil's work, just asking for trouble. So there, this is an interesting group of people. So 19 of them have a vitrectomy, 5 of them have a phaco-vitrectomy because they've got a bit of cataract going on, and then another 5, have a subsequent cataract. And 5 of them, get the usual intraoperative retinal tears and endolaser and gas and no detachments. These people go on to get cataract. So you suddenly realise that these people suddenly really, they're really having a lot of surgery to manage their floater symptoms. So out of that group of 20 people having vitrectomies, 35% of them have now had bilateral vitrectomies, because there's nothing worse than having floaters in one eye. Okay, because you know what optical clarity is like, and I tell them that too. If you embark on this journey and you sort out all the floaters in one eye, you ain't going to be happy with the other eye. And so, so 3 of them actually had vitrectomy in the fellow eye outside the study period. And, of course, 75% of them have had cataract surgery, and 10 before, 5 after, 5 during. And then there's just this increasing trend, I feel, going on with the whole premium lens thing. So I actually think this is just going to become more and more common as we move forward with, premium lenses, increasingly demanded, by a certain segment of the population, and that they're fine as long as everything else in the eye is pristine and everything else is, encouraging, high contrast, because floaters are low contrast. So, if we sort of look back and go, okay, I started with 125 people in the group, 40% of them I thought they were suitable, and out of that group, 50% of them went on to, have a YAG. So that was like, out of the original group, 19% of the original group went to have a YAG, and 16% of the original group went on to have vitrectomy. So on the left, pre-vitrectomy, on the right, post-vitrectomy, same person. That is optical clarity, and that's what these people are after. It's amazing. There's not. Obviously you can't come anywhere near the posterior surface of the lens here, but it's still just, it's pretty good. There's no real fringe. If someone's pseudophakic, if they've got an IOL in here, then I can come absolutely right up behind that plane with the cutter, and probably do a surgical capsulotomy if they haven't had a YAG PC done. You just chomp through that and get rid of everything. So conclusions, it's a good treatment for a subset of people with symptomatic floaters, and basically that is it. That's it. That's all of it. Just these people with an isolated vice ring and not much else going on in the vitreous cavity. Obviously vitrectomy is definitive. Which one? Well, it's just all about that case selection and trying to manage their expectations. And the thing I like about this movie is that they've got, see that is a shadow. That's the shadow of the vice ring. That is the vice ring there. See, that's the shadow. And then this is all the nebulous. See all those clouds. So it's got all three. But that's the thing. That is the shadow. It's crazy, isn't it? You sort of think, oh, there's the vice ring, but actually that's the shadow that's been cast. Obviously I've got a light pipe inside the eye, so I can create some pretty intense shadows. There it is, the shadow there, and the vice ring is just kind of drifting around in this location here. So that really, there it is. There you can see the vice ring there, and the shadow there, and then all this nebulous stuff there. We might as well have started, so we might as well just. So, and it's quite satisfying. That's satisfying. Just just chomp through it all. I'm pretty sure. Yeah, this person's obviously had a PVD, so I don't have to do that step to surgically induce the PVD. Don't think I've got. It's still floating. Yeah, bang. I think it might have gone now. No, it's still hanging around. It's still massive shadow there. Yeah, and then it's funny how the gel moves while you're operating on it. It's still there, little bastard. But I get it soon. Okay, so that's obviously definitive at getting rid of. This is another really good way to show you how the vitreous moves, and so that's obviously asteroid. So about 1% of people have asteroid, and again, my swirling it around just for the movie camera basically, so you can get just an idea of how all that stuff moves dynamically, and that's a soup, isn't it? That's not nice to look through.
Do you do many of these?
Yeah, well, not a lot. It's quite amazing. The people with mild asteroid, often they've got a few floaters. It's not a big deal at all. But this is just removing it, but the thing about the people with asteroid is that they generally haven't had a posterior vitreous detachment. And so, as I said, that when you surgically induce that is the time when as a surgeon, you can't control the forces that are going. This is just real time actually, but pretty. Yeah, so there's a little cutter, there's a little guillotine cutter down the end here, 10,000 cuts per minute. Vacuum's probably about. So here you can see the posterior hyaloid. So you can see the asteroid, staining the posterior hyaloid in a sense. So what I'm going to be doing now, see, I've gone onto vacuum. See how it sort of leapt in there? And I'm just engaged. So this is the bit. It's not a big deal posterior pole, but you'll see this tension line. See that tension line there? Just rolling across there? And so that's separating the posterior hyaloid away. And that is the event. The tears only happen in the peripheral retinas, but when you're, stripping it right out into the periphery towards the vitreous base. this person, yeah, this guy, this poor bugger, it was his only eye. Asteroid, he's had a submacular hemorrhage before in the past. He actually has got vitreopapillary retraction, so the whole thing's pulling on his disc as well. So there's quite a. I'll just fast forward. I don't know where I might. I haven't gone through and edited these videos, but you stain this beautiful blue dye. I think I've peeled it. Yeah, so I've peeled it away by that stage. So diagnosis of PVD. Well, obviously there's the history that goes with it. Peripheral flashes of light, often associated with eye movements. Just again because that gel is swirling around in the vitreous cavity and tugging on the peripheral retina, and tugging on the retina. And the only way the retina can respond to any stimulus, even a mechanical one, is to generate a light signal. So often, they're subtle flashes of light and they might be more noticeable at night. I must say, and even as a retinal surgeon, diagnosing someone having a PVD, sometimes it's not that straightforward. I mean, what I tend to do is at the slit lamp, got the oblique beam of light coming in, and I just get them to, often low power, sort of dial it back, so I've got, good depth of field, and get them to look up and say you can blink whenever you want to, and they look up, and then eventually you just sort of see the posterior hyaloid just sort of, wafting down, okay? And then, so that would be my standard technique for determining if they've had a PVD or not. And of course you can look for the vice ring. And then macular OCT can be helpful as well. Whoops. And this is why it can be helpful because, this person's had a retinal detachment in the other eye. So the PVD event is a big deal in this person's life, okay? And so they've got a perifoveal PVD, and so the gel here will, sort of be properly attached at the temporal aspect of the disc and out here in the temporal, macula somewhere. But, so I can just tell from the macular OCT why they haven't had a PVD, because sometimes, you're not actually sure after clinical examination, or, sometimes the hyalo can still be sitting quite posteriorly, but this person's not had a PVD. Now this is this is the same person. This is a scan through the macula, and you go, well, I can't really see anything at all. So what I do is I just scroll the rest. This is taking the raster up through the superior slice, and then you go, oh right, see it there? So you can't actually see that the hyaloid is attached all the way across here, but you can't see it. But this person's sort of late 40s or something like that. But as soon as you go peripherally, you can see it starting to lift away. So let's go, right, okay, you have not had a PVD, and that's kind of definitive. So that's another useful clue that I sometimes get macular OCT in for. And obviously this is a retinal detachment, and there's, one, two, and there's maybe tear going on out there. And this is a result of all the biochemical degenerative changes in the vitreous cavity, synchisis, which is the liquefaction, and then the collagen degenerating, and sooner or later it turns into a PVD. So about one incidence of retinal detachment in New Zealand is about 1 in 10,000 people per year. This is my photo. I love this photo. I just think this is the most extraordinary photo. It kind of, yeah, and I guess mainly because I'm a geek, but it reminds me of a solar. It's like a solar eclipse, isn't it? That photo. It's just like the moon just, blotting the world out. So in April, we went as a family across to see this solar eclipse off the west coast of Australia. So I've definitely got my solar filters on here with the binoculars to look at this whole thing. And the kids have all clutched, these things here all around their neck, they're all little, solar filters as well. That's a good sort of put up. But this is quite a cool slide that came out of it. This is like 3 blind mice, the early days. 1 minute till the eclipse, and they're all sitting there with the binoculars. And, I did not take that. I just want to tell you that. You need a shitload of fancy gear. Maybe David Hooker might be able to take a photograph of that. I don't know. But it's a crazy thing, and you can sort of see all these flares that happen all the time on the sun, and it's crazy. So yeah, vitreous hemorrhage. Then obviously it's another cause of floaters, another big cause of floaters, and a lot of them are PVD related, and if you've got a significant vitreous hemorrhage due to a PVD event, more likely than not, you'll have a retinal tear sitting there. Okay, so that's why we're pretty hot on early vitrectomy for that sort of group of people, because chances are there's going to be a tear there, and if you sit on it and you've got time plus hemorrhage plus a retinal tear, that turns into PVR, retinal detachment, and a complex retinal detachment, over sort of, I don't know, 4 to 8 weeks, that you can't sort of, different for different people, but and then of course anything that causes neovascularization of the retina, and the big two are proliferative diabetic retinopathy and branch retinal vein occlusions, and then you can get, there's these are the big ones, I guess, that cause vitreous hemorrhage, and there's just a massive list of, fine print. You can get, big bleeds from macular degeneration that can rupture through into the vitreous cavity. That's supposed to be macroaneurysm, sorry. That can bleed as well. I'm sure you know what they look like, and they're associated, generally females, hypertension, trauma, especially young men, but other weird things as well. Valsalva can sometimes rupture, cause bleeds. Terson syndrome, which is when you have a subarachnoid hemorrhage or an intracranial hemorrhage, and for some reason, no one really knows why, they get bleeds in the eye as well. Tumours can bleed, and anything that inflames blood vessels. So this is a really ischemic supratemporal branch retinal vein occlusion, and it's so ischemic that they've kind of shut down the whole arterial supply as well. So there's virtually no blood supply going through this whole quadrant basically, and they've started to grow a tuft of new blood vessels here and up here as well, and they're bleeding. Okay, so sector PRP all the way through there. Why does PRP work? Well, you're doing a graded kill of the retina basically. You're killing retina which has an oxygen demand basically. So if you do enough of a kill, then you kind of match up the oxygen demand of the retina of that quadrant to the oxygen supply. And then as soon as you do that, then you're going to shut down VEGF being produced. Okay, so that's how it works. And then this is proliferative diabetic retinopathy, and I think there's a frond of new blood vessels sitting out here. You can sort of see a trace of, there's a bit of hemorrhage going on here. But the interesting thing about this one is that this is the same person, and this is her fluorescein angiogram. So this is the one that we saw easily. But look at that, bang, 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 bang. All these places are growing, neovascularization that's hard to see. And, probably a tuft at the disc as well. So often it's, useful, not so much for that eye, but for the other eye to go, we need a PRP or not, and you really unmask the true extent of the disease. So this is another cause of floaters. So this was a recent optometry referral, 55-year-old male, still 6'6" vision really, but lots of floaters interfering with daily activities, general vision, more so on the right eye, pretty chronic. What can you do about it? And so you start having a look in there, and I guess this was, so I did a macular, it's like, wow, what's that? Okay, so this person just has, a trace of cystoid macular edema, and you can sort of see a few dots in there as well, actually. So this is, yes, it had PVD, but this is actually, so I go, that's interesting. So then I get them back to do some fluorescein angiography, and actually this is increased. And then this is the fluorescein, and they've got all these, hyperfluorescent spots in the peripheral retina, and you go, well, this is, inflammatory eye disease. So then you start going down the inflammatory eye disease road, and so this is all the tests that I've done. They've all been negative, full blood count, CRP, syphilis, TB, all these antibodies, toxoplasmosis. Chest X-ray was clear. I've checked HLA A29, which is associated with birdshot. That tends to be woman, but I haven't had that result back. So the only abnormal test result I've had is a serum ACE, which can be associated with sarcoidosis. But this person has had a normal chest x-ray, they're not short of breath at all, they don't have any respiratory symptoms, but I've sent them off to a respiratory physician. So in terms of, the summary for that then, I mean, how do you approach, how do I approach inflammatory eye disease? Well, basically there's clues on histories, there's clues on examination, and there's some clues on investigations, and you start putting it all together. So, obviously on the history you're asking about the eye side of stuff, but you really need to go systemic when you think this is an inflammatory eye disease. What's the medical history here? What medications are they on? And then, there's a review of systems, genital, urinary, respiratory, gastrointestinal, neurological, skin, what racial group, things like Behçet's are more common in specific racial groups. Have they been overseas? Could there be in an area where they've been bitten by some sort of tick that we don't have in New Zealand? Do they have any pets, cats and toxoplasmosis? So this is when you really start, these are, often patients, what it's like, some patients are really quick and you can get through them quickly, but these ones you just take a chill pill and you slow right down, and that this is going to take time, but you've got to commit the time to it. So history, and then looking for, is there are there floaters going on here? Chororetinitis, vasculitis, cystomacular edema, and then you start doing all this multimodal imaging of the retina as well, and then blood tests and chest X-rays, and start putting it all together. So I've done the vitrectomy, and so this is that essential part of the operation where I'm searching around. So I've got a squint hook and I'm just indenting the peripheral retina. And searching up and down. I mean, it's sort of washing it all out with light, so you can't really sort of see the detail in the movie, but I'm meticulously searching to make sure there's no tiny little retinal tears that might, lead on to retinal detachment. But the thing that was interesting was suddenly when we go inferiorly, it's still a bit washed out, but I get the light. So this person had a history of inflammatory disease about, 10 years ago, and I thought the whole thing had settled down, but had a bit of a had some floater load, and so I thought got to the stage where it was really bothering her. See, this is over the pars plana. There's just all just inflammatory little dot infiltrates that are just sitting there. You'd never see them until you do an indented. I think so it's really going to come into sort of clearer focus soon. See them there? Bang, bang, bang. Look at that. And that's just, low grade sitting there, doesn't need any treatment at all, but, it was treated 10 years ago, but it's been sitting there dormant, basically. It's crazy. Inflammatory eye disease, well, the vast majority of it is non-infectious. And we sort of have these subtypes, the white dot syndromes. What I showed you before was a low grade pars planitis, so over the pars plana. So, anterior to the anterior limit of the retina, sometimes in this region it comes under intermediate uveitis. It's in the intermediate part of the eye, sometimes associated with multiple sclerosis. And then you have really rare birds like sympathetic and VKH, and then things that can just cause primary inflammation of blood vessels. SLE would be the classic one. And then, like this other guy I'm working out, do all the stuff and you don't find anything at all, actually. The infectious ones that can cause floaters, well, these are the, toxoplasmosis is the most common one. Acute retinal necrosis, well, that's a parasite, obviously. The most common one, viral, would be acute retinal necrosis. You guys aren't going to miss post-operative endophthalmitis. And so I thought I've shown you that movie. Yeah, so the white dot syndromes, these are the ones that don't, I thought I'd just highlight, they don't cause floaters. So no floaters with these ones here, but the other ones can all cause floaters. And this is a photograph of a bird shot, and it is just like this shot that's being scattered around the posterior pole, and there's just these atrophic and low-grade inflammatory things that just have to be controlled with very long-term immunosuppression, otherwise it just destroys their retina. This is mudes. Often there's not a lot to see, but autofluorescence, and I think a lot of you, increasing amount of you, have autofluorescence. So, if someone's got really weird, stuff going on, and autofluorescence is often really good for unmasking inflammation. And the thing about her OCT with the mudes, you can just sort of see, how patchy the ellipsoid line is here. That line here is just completely discontinuous due to inflammation. Toxoplasmosis, this is someone with a primary toxoplasmosis. Obviously it's pretty much took out the fovea, and this is how it looked a couple of years later, just the scar. Acute retinal necrosis. This can present with floaters, with vitritis, and this is just this white necrotic retina, and the arteries are becoming occluded and all the hemorrhages, so the whole thing's ischemic necrotic, and you get holes in the retina, it starts falling off, and they need intravitreal antivirals. And then last but not least is tumours. I mean, no one's going to miss this. This is, massive. I've never seen this. As I say, there might be half a dozen. Talking to Jim, who's, been the longest in the saddle here in the VR scene, he's, over his 30-year career, he might have seen it, 5 or 6 times. But it can just present with vitritis, inflammatory cells. And it can be steroid responsive as well, at least initially. So these people at some stage, if they've got a relentless vitritis that you can't get on top of, having a vitreous biopsy is a good way to go. And I think that is the last slide. Thank you very much. Thank you for your attention.